I'm from California. A little bit about me. I originally hailed from Nigeria, and I went to study in California over 20 years ago, where I did my PhD in cancer research. And of course, you know, as America will want it, you have to get your license and then the degree again. So I have to go back to school again and do everything all over again in the United States. I want to present today on something very, very important to all of us, and I hope that we can all improve upon it and start something here in a big scale in Pakistan. I'm going to be talking on the dentist and early diagnosis of cancer and other diseases, which is saliva diagnostics. Soon and very soon, dentists are no longer going to be just drill and fill and just come in and go. We're going to be a point of line that you have to determine a lot about people, about what they are going through, about sicknesses and concerns. I like it when Professor Navid said, when you look at one of the slides he presented, which you have tuberculosis of the gum. Not too many people realize that a lot of tuberculosis can be shown right within the gum, and also the instances of the discriminative gingivitis. These are something very pertinent. Our body shows up in our mouth, and our mouth shows up in our body. That's my mentor. I got to give honor to whom honor is due. He trained me, Professor Emeritus now. It's Francisco Capelli, an Italian-American, my mentor at UCLA. I want to make a mention of Professor T.W. Wang. He's one of the pace setters of saliva diagnostics. And I learned a lot from him. And his lab has done a lot of pioneering work in how you can use people's saliva to detect early cancer, and not only cancer, to be able to see every aspect of their body, what's happening, oral cancer, lung cancer, pancreatic cancer, breast cancer, a lot of systemic disease. All they need to do is identify their spit, send it to the lab for molecular analysis. So Professor Wang has done a lot of pioneering work at UCLA. It's a very known researcher, and a lot of saliva-based tests for early detection of oral, lung, and gastric cancer. I read overall his work has the potential to revolutionize medicine in the near future, which you're going to see soon. I'm trying to target these particular 4 categories of people here today, and I hope we have all the 4 here, but if we don't have it here, we got to get them involved. I know the dentists and the dental team are here. You're my colleagues. You're all here. Investors, we need to get them involved. Sometimes dentists were too busy with the science. We don't want to talk the money. Yes, you have to talk the money so we can take research to the next level. Professor Navid said again, which I heard, research is good, brings knowledge, not only for us, also for the benefit of the public. We need to bring entrepreneurs, and of course, we need to harness our universities and public institutions to help us out. I'd like to play this video. It's a 4-minute video. Just listen attentively because that captures today, and I'm going to develop on it. Can we have the volume increase? Do we have the volume? Oh. Okay.
Now, the healers of the belief. Right now, systems for 20.3 million cases diagnosed worldwide this year. 10 million people qualify by God. In high ranges, breast institutions have over 90% 5-year survival. In low diseases, up to 40%. Same diseases. Why? Access to diagnosis. But cancer is just looking. 252 million people are walking around with diabetes and have absolutely no idea. 40 type diabetes are completely unaware of complications, kidney failure, amputations, blindness. That's 2 million 80% in low and middle-income countries. Many of them never knew their risk of heart attack, and their cirrhosis. 10.6 million people infected, 1.6 million dead, and 3.1 million cases that simply vanish into thin air every year because they're never diagnosed or reported. HIV, 40.8 million people live, many on American stats. Oral diseases, 3.7 million people suffer, over 1 million severe gum disease alone. 2 billion people, 1 in 4 lives so remote that a simple diagnostic test even hours to travel, a day's wages lost, or minutes to sell. Not for lack of technology, but because we still depend on basic, costly, and inconvenient methods. Approximately 10% of the global population suffers from the globe. The pattern is really clear. Late diagnosis skills. But what if this niche solve fix all of this? Saliva. This judgment body contains biomarkers, which are traceable substances that can detect and predict disease without immediately being able to produce less anxiety than traditionally drawn blood and less embarrassment than providing embarrassment. But advancement and sharp rise in acceptance over the past 20 years to accelerate diagnostics, we can screen biomarkers with a single sheet on or drop of saliva. Today, the analysis of 1 million dropped per stick can detect over 100 diseases across multiple categories, including infectious, autoimmune, metabolic, genetic, cardiovascular, and oncologic conditions, oral disease, and having potential to save your life. It is not invasive, scalable, faster, acceptable, often cheaper, easy to store, and modern treatment today. 3 powerful and impactful ways to take cellular diagnostics to every other with routine checkup model, at your dentist doctor or local health center. You walk into your dentist clinic for a cleaning, or visit your local primary health center for a routine checkup, a saliva sample is collected, the clinic sends it to a nearby lab to test for signs of diseases. Just a quick chairside test, and the machine can diagnose forever. Now every clinician, whether a dentist or physician, becomes the first line of defense against global health crisis. But not every clinician. The mobile man model, when healthcare travels to you. In remote villages, village areas, or dense rural belts, access itself becomes the first barrier. So here, a mobile diagnostic van, equipped with saliva collection kits and a small testing kit, travel from village to village. All over saliva samples and send to regional labs for confirmation. This model breaks the wall between where health areas and where it's needed most. Because sometimes, the biggest step in saving lives is taking that first mile to reach them, and then comes the next solution, always the saliva test. We telehealth and home, testing from the comfort of home. A small, easy-to-use telehealth that provides the doorstep. You follow simple instructions, collect your saliva sample, seal it, and ship it back to the lab. Within hours, the results are ready online, and you don't need to lose them with your consultation. No rooms, no travel, no stress. This model isn't just about comfort, it's about continuity. It helps patients monitor chronic conditions, track treatment response, and stay connected with their healthcare team from anywhere in the world. Together, these models create an ecosystem where diagnosis is no longer limited by distance, either or cost. A world where early detection becomes the new norm, and a market opportunity. Let me show you the numbers. The global diagnostics market is projected to cost $150 billion, and non-invasive molecular testing is the fastest growing segment. We have the science, we have the technology. What we need now is the will to act.
Yes, the drill is cool. Yeah, while I was at UCLA, one of my studies was on biomarker research, and I published this paper as part of my dissertation. One of the things I wanted us to know, part of my summary of my dissertation then, is molecular factors are way ahead of histopathology. That's why when you are when the surgeons find people trying to cut segment of cancer in the surgery room, after taking a section of the cancer, they go to normal tissue width to cut an extra section away so as to prevent recurrence. That's to show you molecular factors are way beyond the real original margin of the edge of the cancer. The chemical molecules, RNA, DNA, that gone way past beyond. So the surgeon cuts a resection, oh, this is the end of the tumor, but apparently the molecular factors are way advanced of that margin. And that's why surgeons get some natural resection area other than the cancer area. But sometimes it doesn't come enough because the molecular factors are way beyond that localized area. Tumor sections are already gone into the bloodstream and in other areas of the body in which saliva is one of them. One of the other things that we find about that, we should monitor people progressively. Most of the time we monitor people just based on, oh, you come to the clinic and then, oh, you're fine, everything is okay. No, we need to go way beyond that to a molecular-based assessment of an individual in order to study and to preclude recurrence of diseases. Not only on clinical assessment, but on molecular basis assessment, so that as we assess people on a 6-month regular interval for cancer not coming back, we are not only doing it on the clinical level, we are doing it on the molecular level, and of course on the histopathology level. And finally, I call the word osteoproteomic approach. In other words, shall we compare me to me? We are fond of comparing everybody to the environment and to the database of the world. Why not compare me to me all the time when I come? Do you have my profile? Dentists, we do it. We don't know we do it. When people come to you in the periodic, you look at their bio, oh, 6 months ago you didn't have caries. Let's look at the X-ray 6 months ago. Oh no, it looks as if it was about coming, but now it's really big cavity. That's essentially what you're doing. You are comparing that person to that same person. In order to get to precision medicine level, we must learn on the molecular basis to compare people to themselves. My molecular signatures are way different from yours. My clinical presentation are way different from yours. The same two people with the same type of breast cancer have two different molecular signaling pathways that is driving the cancer. Medicine A will work for patient A, but medicine A will not work for patient B, because on the molecular level, the cancer signaling pathway that is driving them is way different. But if you have learned to compare A to A over a period of time, you build a database of repertoire to be able to bring precision medicine to go. And that's what saliva diagnosis is going to bring us. We are so prone as dentists that we have the mirror of the body, which is the mouth. There's no way you will not, by the time somebody comes to your clinic, you look at their mouth. As a dentist, in a very, very fun and smart way, you can kind of talk a little bit about how healthy they are. Particularly men, you kind of joke. You say, oh, how come some people will tell you, oh, no, I just had my lunch. But, I'm very fine to my patient. I just say, oh, I talk to myself. So this mouth that I'm seeing today is not what I see, what you just had for lunch. You've not taken care of this mouth, because there's a lot of plaque and calculus and a lot of things. So the body and the saliva is able to see all kind of stuff over the period of time that we have exposed in there. So what's the mechanism by which saliva gets all these materials? The capillaries, which we know, it gets distillated from the saliva, get into the dose of the capillaries, and be able to get some of these signals from the body. Again, this is the same mechanism here. You find out that in terms of the, let me see, okay. You have solid tumors release what we call exosomes, and they get into the salivary glands and form part of the salivary biomarkers. The same thing in the other way around. Solid tumor can cause some kind of oral biomarker dysbiosis and form part of the salivary biomarkers, which are being studied today for our benefit. The same mechanism here. What are the things that make up the salivary biomarkers that we look at for? You look at for RNAs, you look at for proteins, you look at for DNAs, either circulating DNA, cell-free DNA, DNA methylation, telomere length. You look at for microRNA, circular RNA, and you look at for basic exosomes. So all of these are fundamentals that we can study and look at for to be able to assess diagnosis, particularly early in part of patients that are very at risk. Not only at risk patients, but generally. I don't know whether most of us know, I know that Professor mentioned it in one of his slides, that even oral health conditions enough. Thank you. Oral health conditions enough can affect pregnancy. People have low birth weight, low term birth weight, premature situations, because there's a lot of bacteria so much in their mouth. And because there's a lot of seed of bacteria flowing from their mouth that's been able to affect their babies. One of the pathogenesis is that particularly Fusobacterium nucleatum get attached from the periodontal ligament, goes into the bloodstream, and from the bloodstream can directly target into the placenta and get in there. Or it comes in the way of providing pro-inflammatory cytokines, and the cytokines can affect the baby. You eventually have low birth weight, miscarriages, preeclampsia, preterm weight, sometimes instances of intrauterine death. And most of all these things are not people careful looked at because we neglect our role as a dentist. Or most dentists are not well informed of the importance of what we do and the importance of saliva and ability to be able to help a lot of population way ahead of time. That's another study done, in which case you could find right from the saliva, you begin to find here right from the saliva patients that have Alzheimer's disease. Papa Noah might be having it real quick, but you can get some of these brain tangles that is shown causing Alzheimer's disease right from the saliva way ahead of time, if we do it. Cardiovascular diseases, a lot of stuff that affect the heart, oral and colorectal carcinoma, respiratory tract lung cancers, adverse pregnancy that we talked about, diabetes and insulin resistance. All of these things, we are so fortunate as dentists to have them at the palm of our hands that we can get to know them, and that, but we need to start incorporate them and go to the next level as a provider to be a safeguard of health. You could just imagine, this is a table. I literally just took this table from one of the renowned textbooks of periodontitis. So it's not like something just formed up. Can't you just see what Fusobacterium nucleatum alone can cause? Oral infection, chronic periodontitis, aggressive periodontitis, gingivitis, endodontic infections. Again, advanced pregnancy outcomes, stillbirth, neonatal sepsis, preterm, coronary amnionitis, preeclampsia. Can you see GI disorders, colorectal cancer, inflammatory bowel disease, and all these kind of oral infections, including heart infections? Just one bacteria alone present in the mouth. And the patient comes to you. Sometimes we don't even see the plaque and the calculus. Or sometimes we are not careful enough to debride them and get all of these things out of their mouth. Or sometimes we're not careful enough. There's some patients we need to maintain on antibiotics before we even clean them because of the combination of bacteria that are going to be in there. So again, what are the bases of the saliva biomarkers? Microbial, immunological, and molecular, which we have seen. Saliva is a good oral fluid, and of course, it's a liquid biopsy that we can use so much. Professor mentioned it. And now you can cut sections of biopsy. If you feel the patient comes back, it's mad after 2 weeks because you got a wrong sample that is not adequate enough. Saliva can solve some of that problem. If we upgrade in it, inculcate it, study it, and begin to use it in a very, very massive way. And research has established it. That body is the mirror of the body. And we can see ordinary circulating tumor DNA, extra vesicles from tumors. All of these things are available within the saliva that we can get. We have some tumor DNAs. We have DNAs that just form from just normal cells, mRNAs, proteins, metabolite. And look at all these tests can be used today. ELISA, this is a new test developed at UCLA, the electric field induced release and measurement, and all these multiomics, including artificial intelligence. All of this we need to adopt into the next level. Now, the next question is, as we adopt it, what are the bottlenecks that we have? I'm grateful again. Professor, I don't think I'm mad at you or I'm calling you all the time. I know why I'm saying so. Now, before you adopt new things, there's a lot of bottleneck, just too much. One of the ways we are going to need our universities is to be able to have a consensus statement in standardizing saliva collection and processing. Not only that, to have regulatory and clinical validation barriers with more studies done so that all this can be adopted at the point of care in various clinics as we look globally into the world. I'm moving a little faster because I'm not sure of my time. These are all the methods that we can use in terms of molecular assessment, PCR, methylations, PCR, RT-PCR. Most of the time, dentists are not too much familiar with molecular biology because it's not part of our studies. But one of the things I'm going to propose as we go down in one of most slides is dentists should have a background in molecular biology. I was fortunate to do my PhD in molecular biology and have a dental degree. So it gives me a dual knowledge to be able to tackle problems. But that being said, we should have dentist specialists, dentist scientists who can go to all of these fields and help us to frontier medical sciences. Now, this is an established data point. These are cancers with data of biomarkers that have already been established. I saw in Professor's slide, erythroplacoplakia. You can see that through a ELISA method, it's a protein. This is an established biomarker for leukoplakia and erythroplacoplakia. You can see here pancreatic cancer. mRNA, microRNA method can be used to get mRNA, and this mRNA is a multiple marker for association of pancreatic cancer. I'll go again, GI cancers, gastric cancer here. You can use circulating free DNA, and you can find these. These are all established tables. I can make this table available to us if we need it, but these are already established data point for salivas. Now, let me go to practical statement, insight for the dentist. Again, I talked about this. Dentists, we need to begin to see our patient periodically. Yes, we should clean them, debride them, get those germs out of them because they have implications for the entire body, including their heart. We should begin to starting to see value additions for our patients in terms of using saliva and assessment of all the patients. Hopefully, we can get, I don't know whether it is in Pakistan already, but we can connect with a molecular diagnostic lab. Let's build a team together to build a world database of biomarkers. Remember, these things are going to be differ race by race, location by location. The data in North America is not going to be data here in Asia. So don't they, they're already doing it in North America, we don't need to do it in Pakistan. Yes, we have to do it. I'm pioneering the situation now for Africa, particularly for Nigeria. So we have to do it. We should prepare for the next level. Either we like it or not, there's going to be next level point of care devices that's going to be saliva based, and which will be used in our clinics and hospitals, and we need to be part of it right now. I would particularly advise us maybe down the road if you go to salimetrics.com. This is a lab right here in Casper, California. They've done a lot of saliva diagnostics. You can see a lot of videos there, learn a little bit more. And if you want to be a partaker with some of their work, be able to benefit from it. For the investors, they may not be here today, but something is known. Saliva is cheap. Everybody makes it and throw it out. People don't even do it on the street without respect to another person. They just spit on the ground. It's very available. It's economical. It's easy to cheap. It's safe. You don't really get HIV from it. It's non-invasive. You can easily collect it. People can collect it on their own themselves. And if that's the case, we already have companies right now that are providing saliva collection and diagnostics. They're doing that. We have companies right now that are doing non-invasive saliva diagnostics. This is where we need a lot of investment, point of care diagnostics. Most of the time, dentists, we don't think money because, yes, we need to think our patient care. But I'm talking of $1 billion economy here that we can all jump into. That you can use your knowledge and database to be able to team up with you and begin to design point-of-care devices that can help in the future. The truth is, either we stand up or not, saliva diagnosis has come to stay. And people are already working on point-of-care devices, and I want to encourage us to participate of the billions of dollars out there. These are part of the devices in the process in which they're making it. And these are data that I put. Just to kind of run the numbers by us. See, saliva collection and diagnosis based on SNS Insider, you are looking at a mass basis of almost about 800 million. And the next projected market size is about 1.24 billion very soon. Again, another company is projecting us at $3.56 billion. So, in terms of non-invasive cancer diagnosis, another company projected it as a market of about 6.5 billion, 18.25 billion. And when you're looking at point-of-care diagnostics, Fortune Business Insight projected it as almost as 30.87 billion and 51 billion very soon in the year 2032. And I hope that some of us here can join me in this pursuit. Let's do it together, not only for the money purpose, but to benefit the future. Because people rather spit and get to analyze their blood glucose level. In fact, there are tests for diabetes right now based on saliva diagnostics, rather than them to be pricked to get their blood assay for them. I'm wrapping up. Insight for our professors, Professor Navid, sir, with all due respect. Professors and all the universities should come up with consensus standard where we can have saliva collection and processing all done. We have regulatory bottlenecks removed, so that we can have some of these tests go into daily clinical areas and to begin to test on a large scale in the universities. We can further research across continents. We can scale up studies. My company, which is Oludent Health International, is already pursuing that in Africa and in North America, even though it's based out of California. And we can build a database for the world to use in saliva diagnostics. And of course, this is about my company. My company is having presence in Africa, in North America, and the goal is entirely to have smart digital devices for saliva diagnosis and preparing for a smart hospital and smart clinic into the future. I'll summarize. Saliva diagnostics will help detect cancer and diseases early. Let us embrace it and save lives. Dentists, the way we practice will change in the next few years, either you like it or not. Let us get ready. Investors, this is a billion-dollar industry. Please team up with dentists to change life. And universities must ensure consensus to bring saliva diagnosis into hospital work for framework. Thank you very much.